Good evening, guys. We're just holding on for a couple more minutes before we start. We will start at 6:41 officially, and the presentations will start at 6:45. All right. Good afternoon or good evening, everyone, depending from where you're joining us from. I know we had some persons joining us last time from India and from the Asian continent. So, welcome once again to ASHRAE Caricom's Coronavirus and Your Indoor Air Quality. We must acknowledge and thank our sponsors for the Caricom chapter and as well acknowledge the ASHRAE Code of Ethics, which we promise to use throughout these sessions. Okay. Thanks once again to our sponsors. To start off with today's presentation, we'll have Mr. Lawrence J. Schoen, professional engineer and fellow of ASHRAE. Larry Schoen is a principal engineer of Schoen Engineering Incorporated, Columbia, Maryland. He is a licensed professional engineer in 8 states and in the District of Columbia. Larry is a fellow of ASHRAE, which is the American Society of Heating, Refrigeration, and Air Conditioning Engineers. And he is the chair of the IAQ 2007. He chaired, the IAQ 2007 Health and Sustainable Buildings and ASHRAE Environmental Health Committee. He chaired as well and the committee that wrote the ASHRAE's position document on environmental tobacco, smoke, and airborne infectious disease. Larry was a engineering manager for property operations at the Roos Company from 1985 to 1995 with a portfolio of 50 million square feet of retail, office, hotel, and mixed-use facilities. Prior to that, he was a design engineer at Jarrows, Boom, and Bulls in New York. He has published numerous technical articles and professionally practiced guidebooks in the field of air quality, energy use, system design, and building operations, and has spoken about these subjects to ASHRAE, BOMA, AIA, Center for Disease Control, CDC, the American Bar Association, ASTM, and numerous other technical, scientific, and government industry organizations. Once again, let's join and thank Larry for being our presenter, and I'll pass over to Larry. Larry, over to you.
Thank you, Kieran. Kieran, is my screen showing up okay with the presentation?
So, maybe you can swap displays.
Okay, swap displays. Let's see how this works.
Yep. Perfect. We see it now.
Now it's good.
Yep, now it's good. Perfect. So
Okay. So you
a
see
little
the
bit.
ASHRAE Caricom chapter title slide,
Yes, correct.
and it's full screen?
Yes, correct.
Good. Okay, let's go from there. So
Thank
you
you.
already gave me that great introduction. Thank you, Kieran. I'm glad to be with you all tonight. I guess the most important thing for me to share is that I'm not a health professional. I'm an HVAC, mechanical and electrical engineer of building services. And I learned a lot from having to chair the Airborne Infectious Disease Position document in its 2014 rewrite. And that's really the other professionals on that group that I learned just about everything in this presentation from. So I'd like to thank and acknowledge them. You can find a copy of ASHRAE's position document, which has a lot of useful information and many good references on the web just by doing a quick search for it, or you can try to find where it's hidden on the ASHRAE website, but sometimes the web search works even better. So I guess the other thing that I feel that prepares me for this is I'm a consulting engineer who does design and evaluation of buildings, but I also worked as the in-house engineering expert for a property management company. So I feel like I have some empathy for the people who actually have to operate buildings on a day-to-day basis. So having said that, the HVAC system, I want to emphasize two words here. One is a role. HVAC system does have a role, but it has a relatively small role compared with all the other social distancing warnings and other personal hygiene warnings that I'm sure you've heard nonstop for the last several weeks. So how do we know, or how do we think we know things about SARS-CoV-2, which is the official name given to this virus that causes the disease called Covid19? What we know about it is only a little bit from the current virus, because as you've heard many times, it's called a novel coronavirus, meaning it's a new one. We don't really know much. We don't have much direct experience with it. So therefore, we extrapolate and we make inferences from the 2003 outbreak of the classic SARS virus, and to a lesser extent from other viruses, because every pathogen behaves a little bit differently and the spread is different. It's not possible to generalize. In fact, there's a lot of discussion within the infectious disease community, and often not agreement, about what the primary modes of transfer are for any particular disease. So I will focus, of course, on more like commercial, institutional, educational, business buildings in this presentation, not so much on healthcare and medical, although some of the principles do apply. So on this next slide, you see the basic chain of infection. This is from the US Centers for Disease Control. On the left-hand side, you have a reservoir, which at the top of the slide, at the top of the group there is a person, and that's primarily the source for this one. But of course, organisms such as Legionella that live in cooling towers, the reservoir could be something different than a person. So then in the middle of the slide, you have this big arrow with modes of transmission. Direct contact, meaning people touch, a droplet goes from one person to another person's mucous membrane. A vector or a vehicle, well, a vehicle in this case, they're showing a bird on a platter, but more likely we would be worried about things like lift buttons and doorknobs and so on. And then, of course, farther to the right, the droplets and airborne transmission are shown. And those are the means by which it gets to the susceptible host, okay, the person who's not yet infected. The mere exposure, as far as we know, to a single virus does not necessarily cause infection. There may be a dose-response relationship. In other words, more increasing your chances. I don't know that. I'm not an expert on that, but many diseases do have a dose-response relationship. And even if you get an exposure, and even if it's considerable, it doesn't mean that your initial defenses will not be successful in fighting it off. So there's a whole chain here, and we're trying to break this chain. Of course, I do want to clarify how I'm going to use the terms droplet, airborne, aerosol. I have heard people use them in different ways. When I say a droplet, it's a larger particle, one that generally falls to the ground. When I use the word aerosol, I mean a small particle, one that travels almost like a gas. And when I say airborne, I mean either one of those. So, as I said, these multiple modes exist. And the bottom line, in the last bullet, is even the best HVAC system, and I emphasize they're the best, can only influence those last two. It's not going to influence the direct contact with a doorknob or handrail. So, given that there's uncertainty about the modes of transmission, what is the building operator, the one I said that I have some empathy for, what are they supposed to do? So in the infectious disease world, they call it infection control bundles. So you take all of the steps at once because you don't know exactly what's going to cause the disease. And that's where we are. So I think I mentioned this. I'll use droplet. I use droplet and small particle to fall within the overall category of airborne. Aerosol is the one that behaves like a gas. When I'm talking right now, certainly when you cough or sneeze, I read about a tragic case in Washington State where a choir group was singing, and if I get the numbers correctly, nobody was symptomatic. Of 60 people, 45 were infected just from singing in the same room. The last that I read, 2 were dead. So this is a serious disease that can spread by the airborne mode. Whether it's these large droplets or these small particles, we really don't know yet. But as the next to last bullet says, even if it's the aerosols, in other words, the ones that remain suspended and travel long distances, because space is three-dimensional, the concentration of those aerosols will decrease inversely proportional to the negative third power with the distance from the person. So the advice about keeping 1 to 2 meters distance is useful whether the transmission is by the droplet that goes short distance and settles to the surface, or whether it's the airborne mode. Just to give you an idea of particle sizes, so the large objects on the screen are a grain of sand on the left and a couple of human hairs on the right. The blue objects, the small ones floating around, are relative size for, a 10 micron particle. The smaller red ones are the relative size for a 2.5 micron particle. Now, even though the virus itself, I've read, is 0.12 microns, in other words, 1/20th of the pink, of the red, small red dot, the virus usually is not traveling alone. It's traveling on a droplet of water that's come from a person. Those droplets tend to be larger than either the blue, the large ones, remember, tend to be larger, the ones that settle, are larger than the blue or the red dots. The ones that can remain airborne, the size demarcation starts either at the size of the large blue one or the size of the small red one. There is disagreement. There is not universal agreement about what size it has to be to remain airborne. But the principle to remember is that, And the important thing is that the smaller ones remain airborne for a longer time, and therefore can travel a longer distance. The exact number is less important. The understanding of the two mechanisms, direct and then aerosol transmission, that's more important. So even the larger droplets that settle to surfaces, though, there's a letter describing some preliminary results in the New England Journal of Medicine, showing that viruses can remain viable for up to 72 hours. Now, it varies by the type of surface. But that doesn't mean that there's a lot left. The decay is exponential. In other words, it drops off, half-life, and then in the next half-life, and so on. So the fact that there's a little bit doesn't necessarily mean that after a long period of time, 72 hours, there's a lot left. But if people are occupying the same space in a building, they are likely to touch surfaces very rapidly after another person has touched. And then if they touch their eyes, and that's the potential for disease transmission. One unpublished study that I saw, unpublished preprint, showed that there was concentration shown on surfaces in Singapore hospitals, and the highest concentration, 67%, as I recall, was found on the floor. So why are the surfaces? Why do we care about this from an air point of view? Because those virus particles, those particles or droplets, can be re-entrained in the airstream and then become an aerosol. So let's look at a slide that shows the mechanism of how that might happen. By the way, this slide is in this diagram is in the position document. So if you'd like to study it longer on your own and read some of the text around it, you can. So this is showing a hospital bed, but the principles apply just as well in any building. So the bed just happens to be about 2 meters long, maybe a little bit less. And here's the person on the right-hand side, and they're releasing both what I'm calling droplets and the aerosol. And the aerosol, of course, is affected. Any particle is affected by these three forces of the drag force against the projection from the person's mouth, gravity pulling it down, and the air currents in the room that are wanting to sweep it around. So the and the drag also resists the falling to the ground. So the large ones from the sneeze will tend to fall, but in this slide they're showing how shaking the bed linens can re-entrain them. Bed making activities can eject them, and then they become airborne once again. So this is what we're fighting with. So I would like to, even though I'm an HVAC engineer, building services, I have worked in buildings, and of course we can't ignore the general policies for a workplace, a building, and an employer. The first one being used quite a bit in the region that I work in, which is the Middle Atlantic, the Washington, D.C., Baltimore area, Maryland, D.C., and Virginia. Many workplaces are simply closed, and some must remain open. So many workplaces are allowing and even requiring people to work from home to the greatest extent that they can, and prohibiting anybody with symptoms from entering the building. It's good to disinfect those frequently touched surfaces, the handrails, whether they be on a stairway or an escalator, lift buttons if there are lifts, certainly doorknobs, hand sanitation, whoops, sorry about that. Hand sanitation dispensers. I hope I'm back in slide mode, presentation mode. Kieran, am I?
Yes, you're good.
Okay. Hand sanitation dispensers would be a great idea if you can get them. I know they're in short supply. And then I'd recommend against doing any kind of food prep or warming that isn't absolutely necessary in any kind of shared workspace. And that would include the coffee station and an office pantry. So personal hygiene, of course, is under the control of each one of us. And to those of us in any sort of position of authority or influence, I encourage us to be very good role models and take this 1 to 2 meter, 3 to 7 foot distancing very seriously. And of course, no touching and handshaking. Within the home, of course, within your close personal circle where people are living together for long periods of time, that's a different story. But in the workplace where it's a more limited exposure, or certainly in the world of commerce, shopping, and so on, keep the distance. Frequent hand washing, because of the surfaces that you touch. We each have to assume that each of us has the disease, as a carrier. And so we have to behave as though we don't want to spread it to other people, but we also have to behave as though we're susceptible. In case we don't have it, we don't want to receive it from others. There's great guidance on the US Centers for Disease Control website, as well as the World Health Organization. So, since we don't know the magnitude, I'll share with you some of the older and more recent research that I've seen. The Amoy Gardens case was one where Hugo Lee and a bunch of other folks published papers about how people in one one residential tower got SARS with no other way to explain it other than aerosol transmission from one building to another. And it was thought to be due to a plumbing trap that had gone dry as well. So the 2003, it seems there's very good evidence for the 2003 SARS virus for traveling by the aerosol route. A couple of recent studies have found SARS-CoV-2 as an aerosol in hospitals in Wuhan and Singapore. So that's also suggestive. Having said that, though, we still, I believe there's a general belief that direct contact surfaces and large droplets are the more likely method of transmission. So the distancing, let's cover the basics and use the HVAC system as icing on the cake to help stop the spread. So what are those strategies? Again, the non-healthcare buildings. Healthcare is a very specialized environment. It's not one that I personally work in frequently. So my guidance is really for the non-healthcare buildings. Outdoor air ventilation will dilute whatever is inside the building if it is airborne. So increasing that to the extent that is possible is likely to help. Anything that's saving energy right now, it's a good time to disable it. The health and safety at this point in the building are far more important than the energy savings. And by the way, I don't know about your climate, but our climate here in the mid-Atlantic this time of year, we don't pay a lot of energy penalty for the air, which is a moderate condition outside. Higher air filtration ratings. I think you've heard some about this already, but emphasizing this again. Higher Merv values. In the European Union, they use a rating called F. The F values, F5 is equivalent. Use at least Merv 9, but I would go higher in the central systems that have the capability. Merv 13 at least, and you can go up to Merv 16, depending on your system. I know there are concerns about increasing pressure drop and reducing airflow. And theoretically, that's a problem, but when I've calculated or observed this in real practice, I've never known it to be a problem. It's a theoretical problem, but I found a slight reduction in airflow, whether by calculation or by observation, and nothing that damages the system or prevents the system from working. Not to say that there couldn't happen, but I have not seen it to be a problem. Running the system's longer hours will improve both the effectiveness of the filtration. Of course, if a system is not running, and has the best filters, they won't do much. For those buildings that are able, and there is some disagreement about how high to go, but it seems that above 30 or 40%, particularly in this moderate weather that we are experiencing, even in some of the colder climates right now, doesn't seem like going above 40% would cause much damage to any building. And there's a possibility of some reduced disease transmission. There are three possible explanations for why higher humidity might accomplish this. One is that those larger droplets, when the water evaporates from those larger droplets, they become droplet nuclei, which can then be small enough to spread through the air. So lower relative humidity makes that happen more rapidly. That's one possible mechanism. Another is that the virus itself might do better at lower relative humidity, so higher might reduce its viability. I don't think we know that yet about SARS-CoV-2, but it's true of some other viruses. A third possible mechanism is the mucous membranes being moisture in the host, the person who might receive the disease, and giving them better protection by moisture mucous membranes. Lastly, to supplement the central system, you could consider portable room air cleaners with HEPA filters that, those floor standing portable cleaners, either in an enclosed office or an enclosed bedroom if it's at home. And that will reduce the particulate levels, those aerosols, and it helps in many ways. So my button is not working here. Oh, there we go. Okay. So here is a slide that has a lot of information on it. But on the left column, Merv levels 1 through 16, comparison with the old dust spot efficiency standard, been replaced by the Merv, the standard that describes the Merv's levels. And here's the efficiency. Oh goodness, it says PM. It's supposed to be corrected to micrometers. Sorry about that. That's 0.3 to 1 micrometer, 1 to 3 micrometer, and 3 to 10 micrometer. And so you see down at the lower level, so take a look at 13, which is the minimum that I recommended for a central system. And again, recall that the particle size that we're interested in for aerosol droplets is in the smaller range. So it's going to be in the 2.5 to 10 micrometer. So it starts at the low end. Well, it starts really at somewhere in the right-hand column, but it gets smaller and smaller in the two columns that say 0.3 to 1 and 1 to 3. So you can see a 13 has 75%, 90%, and 90% removal. That's pretty good. If you go up to Merv 16, you see greater than 95% removal. Now that's at the central air handler. That doesn't mean what's happening in the room. So the performance in the room, of course, depends on the number of times the air in the room recirculates, the air changes in the room, and so on. I mentioned other benefits. My slides are not advancing like I'd like them to. Okay. I mentioned other benefits from better filtration. This is not related to infectious disease, but this slide shows the Merv level that is needed to get the air inside a building to meet the US air quality standard in various cities around the world. I don't know how readable it is to you, but the top is Melbourne, Australia, through Nairobi, Kenya, and there a MERV 6 to 8 will do it. Monterrey, Mexico is in that group. The next group, MERV 10, and all the way down to MERV 16. So those are some of the cities with the worst air particulates in the world, starting with Mumbai, India, Kuwait City, Karachi, Pakistan, Milan, Italy, Nanjing, China, Beijing, China, and Delhi, India. So this is just showing that the higher the concentration of small particles, the better the filtration level needed to remove it. I did mention portable air cleaners. That's a picture of one on the right-hand side. It's hard for you to tell the size of that, but it's about 1 meter tall. And the diagram on the left shows a residence. But the principle here is that the bedroom is the room that you spend a lot of time in. So that's the room you would want to put it in, whether you're protecting yourself from viruses or protecting yourself from outside air pollution. And so if it's an enclosed office, that would be the room where it's probably most effective to apply it if somebody is spending a long amount of time there. The way to size these air cleaners in the US, we have a standard from ANSI AHAM. AHAM stands for Association of Home Appliance Manufacturers. And they have something called a tobacco smoke clean air delivery rate. And it doesn't apply only when you have tobacco smoke. It applies because the smoke tends to be smaller particles. So therefore use that rating and size the portable air cleaner for the room size. It's a little bit beyond my scope to actually go into a sizing exercise, but I'm sure there's good information from AHAM and the manufacturers about how to do that. So I will say, in general, I do not recommend turning off the ventilation system, although I saw that as a recommendation at one point in China. I guess the exception would be if you have an infected individual present and it's known. Now, I don't know why you'd have in a commercial building, I don't know why you'd have the building still operating if you knew that, or why the person would be in the building. Certainly in a hospital, you can't avoid that. But if that happens, I would say, okay, then maybe turn the system off, disinfect. But in general, if you don't have a known, I would run the system, use the benefit of the filtration, which I assume it should have it, and use the benefit of the outdoor air dilution ventilation. So if a system has neither of those, that would be another case where I wouldn't simply run a recirculation system with no filtration and no outside air. That would only spread things around the building. And the other exception would be if you don't have good filtration and you have major outdoor contamination, like some of the cities I mentioned. I did caution you about the over-humidification. I'll show the next slide. Will give you some more information about that. I do not recommend ozone generators. Ozone itself is a lung irritant. Not only is that not good for you in a general sense, but weakening the respiratory system could make somebody more susceptible to infection. And as a corollary to that, there's little that can be said that is comparable about electronic air cleaners to regular media filters. So I would use those with caution. Some of them may emit ozone, and there are not yet good rating systems for all of those. This is a precautionary slide about over-humidifying. I don't know if you see, I doubt if you see any of these temperatures. I know your climate only a little bit. I was once on Isla Margarita off the coast of Venezuela, which I think is not too far. Equatorial climate, I don't think you see these cold temperatures. So this really is a slide which is more meaningful for colder climates. Okay, for high-risk occupancies, this would include healthcare, but I think it would also include waiting rooms, for instance, for healthcare, but also waiting rooms for transportation. Any area where you have a large concentrated population and limited ventilation per person, close proximity that's almost sometimes unavoidable, an unknown situation of individuals, some of whom may be infected. So in those areas, one great technique is upper room ultraviolet. On the left-hand side of the slide, you see the actual irradiation system. It's not irradiating the people. It's irradiating the room in the upper reaches, irradiating the air in the upper reaches of the room, which will travel there by natural convection from the person or by circulation from the air system. Or I have heard of some people deliberately blowing the air up towards the ceiling area in conjunction with ultraviolet. Another way it can be done is, and I've seen this done in People's Republic of China, perhaps other locations, when the hospital room is empty, then they irradiate all the surfaces in the room. And that's been found to be effective for keeping the surfaces clean. So then touching or getting re-entrainment of particles on that surface is not a problem. And then, of course, directional airflow in the room, you want to go for always from clean to dirty, so you don't accidentally get dirty air going towards the clean. And that can either be done with directional flow in the room. It's primarily for high-risk areas, primarily healthcare, but also others. And you can also do it from room to room by having room-to-room pressurization, or even an anteroom, like a vestibule before you go into the protected room that either has the infected or in which you're protecting the uninfected person. Another slide right from the 2019 ASHRAE Handbook of Applications, showing how the UV fixture is in the upper area of the room. The convection currents get the air up there. I have read some studies showing this to be as effective as 3 to 5 air changes an hour, just putting in these UV lights. Now, admittedly, this is something which requires power, requires a fixture, and I'm going to just jump back to the previous slide and point out we don't have the shelf here. Sorry. In many cases, it requires a shelf below the fixture if the ceiling does not have enough height to protect the occupants below so they do not get direct ultraviolet on them. Ultraviolet itself on a person is a hazard. Some fixtures have this built into them so that the fixture itself only irradiates the upper areas of the room. And you see that it's above 7 feet. That's the goal. So it's definitely outside of the occupied area of the room. Here's a photograph of St. Vincent's Hospital in New York City, where the fixtures are actually applied on the wall. And in this case, it's the fixture itself that has the cutoff of radiation that protects the occupants below. And you see quite a bit of density in this room. A little bit of coverage on construction sites for those of us who work or have to go to construction areas or have to at least consider going. So one is construction sites often, but not always, are outdoors. They often, but not always, have social distancing between workers. And workers often, but not always, have some sort of personal protective equipment, including masks and eye protection. Engineers sometimes have to do field observation, of course, commissioning and special inspections. So before I would jump out, run out to a construction site, I would find out, well, can it be postponed until a better time? Can I do it remotely somehow by looking at observations, for instance, on the building automation system? Can I get somebody who's already out there to do photographic documentation? Now, it's not only selfish of me to ask for somebody who's already out there. This whole disease control goal is a game of chance. the fewer people who are congregating, the fewer people who have exposure to others, the more we are going to improve our chances to so-called flatten the curve, not overwhelm our healthcare system. So when I say I don't want to go to the site and I want to have somebody who's already there take the photographs, the key is they're already there, so they're already exposed. I'm not asking them for any additional exposure, and I'm reducing the overall cohort and societal exposure by not going there myself. So yes, there is protection to me and there is a selfish aspect, but it's also the group aspect of avoiding exposure that is of benefit. So if I had to go, of course, I would take the precautions that I emphasized earlier in the presentation, the distancing and personal hygiene. So let's say you're called on to give advice. So I've given general advice in this presentation. If I were giving specific advice, I would take care, and I advise you to take care, to know the building and its systems, its purpose, how essential are its purposes, and how is it used? How many people are there? Has the owner done all of the basic things? And you can advise them about the HVAC system, the things that we mentioned, better filtration, more outside air, reduce your saving of energy at this time. But remind them it's not the first line of defense, and any risk reduction is not elimination of risk. I wrote an article for ASHRAE Journal. It was published in the newsletter March 24th. You can look for it online. The handbooks, as we mentioned, have great information. BOMA International, Building Owners and Managers. They have information on their site. Urban Land Institute has information, and of course, for basic health information, the health authorities that I previously mentioned. So, in summary, the HVAC system is not the first line of defense. It's something you can do in addition. If you're advising building owners, if you're in the business of operating a building, make sure you've done the basics. What we can do we're not designing a system in the short term. So basically what we can do is increase the outside air, in the short term, is increase the outdoor air and the level of filtration. Filtration technology of what can fit in a small package with a reasonable pressure drop has improved vastly in the last several years. Increase the outside air if the outside air is clean. Maybe not in the Caribbean climate, but if the humidity is less than 30 or 40% and you have systems, humidify. Be aware that long-term humidification has its risks, but in this short-term crisis, if I were operating a building and I had a humidification system, I would use it under these emergency circumstances. The other advanced techniques such as ultraviolet and pressurization, one-directional airflow, and anti-rooms in the higher risk areas. I'll be staying around for questions, and any questions that you don't get to, I don't get to in the time we have available, feel free to email me. You can email me directly. You can approach me through Kieran or through the chapter. And I will turn it back to you, Kieran, to let me know what to do next here.
All right, Larry, we have a couple questions. Hopefully some more questions come in about your presentation. One of the questions comes from Bashish Sirju Singh. The question is, do you have any data on airflow drop with these specialized filters, the Merv, the F series you mentioned? Not much, but may give us a CFM drop-off? That's the first question.
I'm sorry, a CFM what?
The CFM drop-off. Do you want me to repeat the question, Larry?
Drop off? Did you say drop off?
Like
yes.
The pressure drop impact?
Oh, okay. Yes. So first of all, I'm going to try to find the right button so I can share my camera and so people can see me as I'm answering. Did that work?
Perfect.
So yes, first of all, try to find a low pressure drop filter cartridge filter element, and that can be done with the pleated filters. They increase the surface area without necessarily doing too much damage to pressure drop. But even if you increase the pressure drop a little bit, in my experience, when I've done calculation, in most systems, in the overall pressure available, the filter pressure drop is a small part of the overall. So it will have an effect on reducing airflow, CFM, but I have not found it to be major either when I've calculated it on an overall system or when I've actually done it and observed systems where people have done it and increased the filtration level. So it's a theoretical risk. I have not found it to be a major risk in practice. That's my own experience. Not to say it couldn't happen.
Next question that I have for you, Larry, is from Ian Weeks. He said, "Don't over humidify." You said you don't over humidify in the winter, but in the Caribbean we generally have high humidity year round. What would you recommend as an optimum RH, relative humidity, to prevent favorable conditions for viruses?
I'm not a virologist, but from what I've heard from those folks who are, different viruses and different infectious organisms behave differently in different levels of humidity. So having said that, the general consensus seems to be to keep the upper humidity level below 60 or 65%, and ASHRAE standard 62.1, the latest version, actually has a wet bulb upper limit. And the advantage of that is it implies also at unoccupied hours. So I'm not going to quote the wet bulb limit because I don't have it in my memory, but certainly I would look at ASHRAE standard 62.1 as that upper wet bulb limit. And if you're looking at relative humidity, 60 to 65% when you're in the dehumidification mode. When you're in the cold climate mode of adding humidity, I wouldn't go above the 30 or 40% and even lower at the very cold climates, as the slide that I showed previously about maximum humidification recommendations. So I hope that answers the question.
Perfect. And the last question that actually we have two more questions for you, Larry. Based on your experience in the Caribbean, based on our experience in the Caribbean with mold growth, we tried to keep the RH at less than 56% and closer to 40%. What are your recommendations?
Well, it's a complicated process because it depends on the building envelope, how insulated it is, and so you may have conditions down there that I'm less familiar with. So if the general experience is that avoids mold and moisture problems, I wouldn't argue against it, that keeping it at the lower levels in your climate. Perhaps the building envelopes are leakier, perhaps the insulation level's not as high as what I'm accustomed to. So that's what I would say for general mold and moisture control. For this particular organism, SARS-CoV-2, about which we know very little so far, it does not seem that 40% would be a problem. So I've seen nothing that indicates that 40% would be 40 to 50% would be a problem. So if you're finding that successful for avoiding mold and moisture, I would continue to do that.
Okay, and the last one that I have right now is actually from Robin Bryant, and she's mentioned that they're currently working on a recommendation document to be published in Florida, and it limits up to 60% relative humidity. So any comments on that, Larry?
I mean, that sounds like it's consistent with the Florida also would be more in the dehumidification mode as opposed to the humidification mode. So keeping that 60% limit is reasonable. But again, I would encourage you, I wish I had the number in my head. I would encourage you to look at standard 62.1, where they give a maximum I'm sorry, I said wet bulb, I misspoke. It's a maximum dew point temperature. And Michael, maybe I see you shaking your head in your video.
Yeah, that's correct. Yeah, that's correct. Yeah.
Is it
And I don't remember the number either, but
okay.
Yeah.
So maybe when you start presenting, maybe I'll look it up.
Look it up.
Put it in the chat, and we'll get the right number.
Yeah, there you go.
So my answer is 60% sounds reasonable, but I would look at the current recommendation for dew point control, because that addresses not only the occupied periods, but the unoccupied periods. So if it gets a little bit colder or a little bit warmer in the unoccupied period, it might change what you do a little bit.
Okay. Cool. Let me see if there's any more questions. Okay. Ian mentioned that the dew point should be less than 16.8 degrees Celsius.
Is he reading that from the ASHRAE standard?
I am guessing so, yes.
Great, thank you.
Okay. Any more questions for Larry before we transfer over to Michael? I don't think we have. So Larry, thanks again for your presentation. If we do have any more questions, we definitely will be reaching out to you to give you some feedback. And if you have any questions, Larry's email is at the bottom of the screen. You'll also get an email from us with his email address, so you can reach out to him if you're a bit shy and not wanting to ask the questions in this forum. But thanks, Larry, once again. And let's transfer over to Michael.
Okay, thank you.
Michael, are you all set?
I'm all set. I believe I'm all set.
Okay.
All right.
Perfect. So let me just give thanks, Larry, and let's welcome Michael. Michael Sheerin is the Chief Executive Officer and Chairman at TLC Engineering Solutions Incorporated, a national top 20 full-service engineering firm headquartered in Orlando, Florida, with nearly 400 staff in 13 offices across the USA. TLC provides MEP, structural, technology, and energy and CX services for owners seeking high-performance buildings, designs, and operations. In addition to leading the strategic direction of the firm, Michael is actively involved in the codes and standards development process that impact the healthcare industry. He currently serves as the chair of ASHRAE Standard 170, Ventilation for Healthcare Facilities, and is the chair of ASHRAE Standard 189.3, Design, Construction, and Operation of Sustainable High-Performance Healthcare Facilities. His project experiences includes the planning of the Washington Adventist Hospital, replacement in Silver Springs, Maryland, and the Nemours Children's Hospital in Orlando, and the campus expansion at Piedmont, Atlanta, and the Children's Hospital in Cairo, Egypt. And I see, Michael, you found our Children's Hospital in Trinidad as well.
We did. We planned that facility as well. That's correct.
Awesome.
So.
All right. So
you ready to go? All right. Well, thank you so much. Thank you so much, Karen. Larry's given us all a really good overview and understanding of the virus and of how to approach and what to think about for non-healthcare buildings. And I'm going to try and carry that forward a little bit further with the things to think about in healthcare buildings, and then also some of the conversations that have evolved around adapting other building types for potential use in an overflow or surge capacity for healthcare. So we'll talk about a little bit of that in my presentation. The information that's been developed here has been developed somewhat on the fly in the last month or so with our 170 committee. The ventilation of healthcare facilities standard 170 is also found in the facility guidelines FGI book that is the kind of Bible of design for healthcare facilities in the US and is a resource in a lot of other places, and a handy guide in many places for the design of healthcare facilities. This presentation wouldn't be possible without the expertise of a lot of folks, both in ASHRAE and in ASHE. ASHE is the American Society for Healthcare Engineering, and it is the organization that represents primarily the people who are the facility operators, the facility directors at healthcare facilities in the US, and we'll refer to some information that they have available that we think is also beneficial to people everywhere. So a little bit of perspective, the big challenge that many places have that we are suffering from. I'm in Florida, and in addition to the fact that testing is only catching up to cases, there's also a lot of instances where people walk around and they're asymptomatic, meaning they don't show any symptoms, and unfortunately they convey the virus to others, usually at a rate of 2 to 1. So if one person is asymptomatic but walking around, it is a common experience that unfortunately 2 people become may become infected with the virus as well. And so what ends up happening is, as they have seen in epidemiology circles, is that the true number of cases is significantly less than the number of cases actually exhibited out there. Larry Schoen addressed this. I would only reinforce that the viability as it's an aerosol seems to be less than around 3 hours. That's still a large window of time for something to be addressed, and certainly there's greater concern either when you're very close to a person who's a source, which is is going to be frequent in instances where you're a healthcare provider and you have to be close in with someone that you're caring for, and certainly even more so when you're doing something like intubating a patient, which is putting something down their throat in order to effect care or put them on a respirator. And so it's unavoidable high level of potential risk in those instances. And so those are the things that we have to think about when we're dealing with healthcare facilities, is that they are potentially places where there's a higher concentration, perhaps because of what's happening or the care that's being provided that helps them get to the next stage, and hopefully the next stage is them getting better. A lot of the conversation is everything is geared toward flattening the curve. Flattening the curve doesn't mean reducing the number of cases in actuality, or it may reduce the number of cases, but the bigger issue is it's spreading out that number so that which means two things. There's a longer time duration, so we're all stuck in our houses a little longer. Be patient, all of you, myself included, be patient over that fact. But it also ensures that we don't overwhelm a healthcare system that we have available to us. And that's going to be the most important point with all of the conversations around preparedness, because unless we truly know and are fully locked down, if you will, and minimizing the interactions of people that result in the potential for the virus to move person to person, we are always going to be up against, well, what is the capacity of our healthcare system, and can it support the needs that are going to that it's going to face? So, for example, and I'm just using as an example the state of Hawaii, because Trinidad and Tobago, has about the same total population. Hawaii, it's like 1.4 million, and there they have right now projected that the ICU bed capacity that they will have available, 45 beds, is significantly less than the worst case or the present case projections of 177 ICU beds being called for at the peak, at the apex of their expected COVID activities, event, if you will. And that's a real challenge. That's a concern. From a total standpoint, the number is workable, and I didn't take a frame shot of that particular graph, but essentially their total number of beds, which is 2,583 beds, the total number of beds that they needed was just for COVID patients was less than that. Obviously, all of this assumes that you are not using the beds for any other purposes other than truly emergency cases otherwise. Just for reference, Hawaii has, I believe, about 280 present COVID patient cases and 1 fatality. And I know that Trinidad has 90 COVID cases, which is great that it's significantly less, and 5 fatalities. And so hopefully you're in a better position. Hawaii being obviously a transit point and a place where a lot of a high Asian population and connectivity to the Asian and Pacific region, they were likely exposed to more at the onset, and that likely has been an impact as to what they're seeing today and what they're going to have to work their way through over a while. So as places move, as the patient population moves from suspected cases to COVID positive patients, there's going to be a desire to commit those patients to an airborne infectious isolation room, and because that's the best case practice would be putting them in a room where you can manage and ensure that that anything that they're discharging as they breathe is removed directly out of the room, and that's protection then from any other patient in adjoining rooms, and also continually provides a greater level of protection because of the higher air change rates in an airborne infection isolation room for the staff, the healthcare workers that are in and out of that room constantly to care for that patient. The CDC, recognizing that the potential exists that many facilities only have a certain number of airborne infectious isolation rooms, has recommended that the airborne infectious isolation rooms be used only for patients where you're likely going to have them undergo an aerosol generating procedure. And there are examples below that in the slide about what those procedure types are, but any of those procedures are procedures that you know, can create you know, the discharge or coughing or things along those lines. In the instance where you have a large number of cases or expect to have a large number of cases, the action that is recommended by CDC is designating an entire unit, and what that means depends upon the facility, but perhaps it means multiple patient rooms or a ward in an area, and commit that area, or an entire floor or half a floor of a patient tower, perhaps, for the use of you know, suspected or positive tested COVID patients. Clinicians have advised us, we've talked with folks that are on the medical clinical side, against putting people who are suspected COVID patients, putting them in the same area with confirmed COVID patients, because unfortunately what may happen is the potential of even just the fact that staff are moving and interacting with those patients may result in the mistaken or errant conversion of a patient from a suspected patient to exposing them just by those levels of interactions. It's you know, staff are going to be moving quick, and you know, those things can happen mistakenly. So a number of facilities where they are anticipating higher numbers of cases have taken to managing their emergency department entry points and all of their entry points to make sure, or to limit access to the hospital only to staff and patients. And with the emergency department, as all emergency departments typically are the first point of entry for a lot of patients, how can you deal with that more effectively? And some facilities have set up a tent type facility or an alternate care site, and we'll talk a little bit about what those options may be later. But dealing with folks before they come into the actual hospital, because once they're in the ED, if they're COVID positive or suspected and actually positive, they could expose others, and you don't want that. And two, if they're sick but they only need a test and can self-care at home, then you want them to get a test somewhere where you can safely do that, and then advise them to go home, and when test results come in, and they'll know to quarantine themselves, to continue to quarantine themselves, and then only at the point where they have respiratory care issues would they actually need to come to the hospital. I would very much highlight the fact that you know, unfortunately, which I believe was the case with the fatalities in Trinidad, that higher, you know, folks who are older, folks who have comorbidities, hypertension and you know, diabetes and such, are at much greater risk for, and so it is very important that we certainly encourage that nursing homes and assisted living facilities would consider strong measures, both in regards to, you know, in ways of protecting their residents, which may include, you know, checking the staff every day for their temperature, and then also either checking their visitors, or as we have seen in hard-hit areas like Seattle, and as has been applied here in Florida even, is starting to restrict visitors altogether, out of the necessity for protecting the residents of those places. So if you were a healthcare facility operator or are working in support of healthcare facilities, what would be some right-away actions that we would encourage? The first would be, verify that your airborne infectious isolation rooms are working properly the way they're supposed to. And then verify that your emergency department HVAC system is in very good working shape and meeting all of its performance parameters. HEPA units, the portable HEPA units that you may use in order to either create additional airborne infectious or surge type rooms, would definitely encourage that you secure as many of them as you can, and then as well secure them where they are either going to be deployed or in a safe place so that they're available when you need them. And then, really work with your clinicians to establish what is going to be the surge plan, the temporary patient segregation plan, and then put whatever working efforts are into that now so that everything is ready, whether you ultimately need all of it or only need part of it because you are over ready. And being over ready is always going to be a lot better in a healthcare facility than not ready, because it means the matter of the survivability of the patients, and those patients may be your family or my family or somebody else's family, and then also the safety of the healthcare workers. So, some basic thoughts. We want to do things that bring no harm. So we want to be smart about the things that we do or alter or change. And then anything that is done should be done for the benefit and the protection of the workers, and then the protection of the patients and the other patients in other spaces. And as always, the airflow should be from clean to less clean. Larry talked very effectively about all of these items. I think the two important things to note, one is that recognize that the virusol may be aerosolized during toilet flush, and so how the housekeeping in that space becomes an important issue, and also an exposure issue to the workers dealing with that. So keep that in mind. And then the study, the pre-published study that Larry mentioned at one point during his presentation, one of the important items that I felt like came out of that was that during the first week of a patient being in a hospital, was seen to be the time when they were most spreading the virus. So after the first 9 days, the amount of contaminants or droplets that were COVID, that tested as COVID particles, after 9 days dropped down. So during those first 9 days, it actually was higher, which means they may not be as sick at that period of time. They may still be sick, obviously, and need help to the point where they need to be in a hospital, but they may not be as sick as they might as they move into an ICU or whatnot, or at least they aren't dispelling as many particles that could be problematic for healthcare workers and so forth. So I don't know how we use that particular information, but I think it is very important ultimately from a clinician's perspective. And that information comes from a research study in Singapore. So the healthcare work, the HVAC systems, it's important to remember there's the real impact, and there's also the confidence inspiring impact of knowing that as healthcare workers go into a space, that the efforts have been made to make that space as safe as we possibly can for them. And that's why we look at trying to adjust or trying to at least ensure that the systems that are in place are the right systems, and that we've done everything that we can in regards to that. Like I described before, an airborne infectious isolation room has 12 air changes. That's you can see that in ASHRAE standard 170, and all air is actually exhausted out of the room directly to the vertically outdoors. You know, in establishing solutions beyond an airborne infectious isolation room, and when I mean beyond, I mean in those instances where you're anticipating more surge cases and the clinical plan calls for doing something. You know, the question of what that something is both predicated on what you can do, and then also what is going to be acceptable to the clinical team. So the elements of that may be creating negative relative pressure of a space to keep the contaminants within that space, contained within that space, increasing or changing air changes, or at least maintaining air changes so that you're diluting the contaminant level in a space. Exhausting the air, which is removing contaminants from the space, from the system altogether, and then filtration, which obviously captures contaminants. Keeping it, keeping your approach to within the time constraints that you have, and then also within the time, the mental energy and the dollars that you have. Are all going to be part of the approach that you need to customize and take for when you're dealing with the circumstances that you're faced with. You know, some of the things that we have seen with other facilities is, obviously, I've said, work with the clinicians, establish some minimum standards. What are the things that are the expected standards? And how then you deploy a plan can be easier accomplished because you know what your standard is that you're reaching toward, and then it defines what your actions will be. Identifying the areas and then ultimately the rooms or suites that you are going to be doing this with, recognizing that you should not sacrifice life safety over creating these spaces. This is very important because one of the things that we'll note a little bit later is there is a good amount of oxygen consumption needed because of the respiratory illness component of the disease, of the virus, and you don't want significant O2 consumption and then also be shortchanging your life safety practices. And then make a floor plan, make a map so everyone knows where these areas are that these patients are where these patients are at. The most basic approach is put a patient in a room, close the door, and use your safety protocols. That is what we would refer to as a passive isolation method. CDC, advises that as a first course. Like anything else, it's a matter of really identifying or anticipating what your patient load is going to be and what the acuity level of that patient load is going to be, and then really developing a layered approach from there. So that may be the first order is a passive isolation approach with your certain level of patients that need care, but don't become more acute perhaps. But beyond that, it's really identifying what is the layered approach that's going to meet your needs by what your anticipated patient load is going to be. And there's, with that comes a small scale surge capacity mode, and then a larger scale surge capacity mode. And really, a lot of this is dependent upon what you would anticipate your patient load is ultimately going to be. So the small scale would be, creating additional either dedicated airborne infectious isolation rooms, or creating temporary patient observation or segregated rooms that are committed to COVID patients, and they have either HEPA or negative HEPA and negative pressure in those spaces. And then the large scale surge is perhaps dedicating an entire ward or suite for the same approach. It is important to make sure that clinicians understand that a temporary observation or segregation room may not be the same thing as a true AII room, where it has the 12 air changes and the exhaust goes directly to the outdoors and things like that. They may not care as long as it's effectively doing the things that you as a team set up the standards to do. When we talk about HEPA units, just as a quick aside, what I would typically refer to a HEPA machine is, or a HEPA unit is these machines that you will commonly see when healthcare facilities are doing some construction and they create some temporary barriers. Sometimes they're pre-assembled units, like the vestibule type units that you see here. And then we have also seen facilities that have made an ad hoc assembly themselves out of necessity, out of the need for extra units. It's important in all of these cases to remember there can be a noise factor, and so your placement of these units, although maybe as a secondary issue to what it is doing for a patient safety and for worker safety, there is a concern, or there could be a concern if it is too noisy, that patient care could be compromised. So keep that in mind in the placement of this equipment and how it's run. So, just to dispel some questions that have come up about HEPA filters, yes, the virus particle can be 0.1 micron or smaller. And Larry talked a little bit about this in regards to Merv ratings and so forth. But we do hear this come up a little bit, that, well, the virus is 0.1 micron or less. Is that a problem? And the answer generally is no. I mean, that's not 100% the case, but the fact of the matter is, most of the time, the virus has carried it in an airborne capacity is almost always probably greater than 0.3 to 0.4 micron in size anyway, because it's encapsulated in a liquid or mucus. So when Larry talked about droplet, and airborne, all of that is part of what a HEPA filter is going to capture. And so it is an effective contaminant removal mechanism. And the same goes really for N95 filters. N95s are certified to filter at least 95% of airborne particles, and they're tested at 0.3 microns. So it is a very effective worker protection tool. I would say there's been a lot of talk about the reusing masks and other things, and I would definitely refer to you to some of the information out there about reusing them, because the availability of replacements is certainly an issue in a lot of places. So this is the chart of just you can see the efficiency, because HEPA filters are tested at 0.3 micron, they actually are the least efficient, which is still 99.97 at least efficient at 0.3, and they're actually better efficiency at particle sizes above and below. So I won't go through each one of these. There'll be some discussion on specific patient room layouts in the next couple slides. But I would say there's a variety of approaches, and each of these approaches that we'd want you to consider is really related to what is the circumstances at your facility, and what is going to be the appropriate approach based on the systems that you have, the modifications that are going to create the best outcome for the arrangements that you have, and the air balance and other conditions around what your facility can support. A couple items to remember, reminding healthcare workers, if they turn off a HEPA unit, then you're especially if you're exhausting to outside, you can actually create an unsafe condition, because the room could become positive pressure to the corridor, and now you're transferring contaminants into the corridor, which isn't acceptable. So a couple approaches that we have seen in converting a space. So here, this is a HEPA unit, and it is actually discharging out the window, or something along those lines. Basically, it's discharging directly out. Obviously, it needs to, even though it's HEPA filtered, you'd always ideally want to discharge it in a safe manner. And here you would seal off the return grill. So what that means also is that when you do that, this room becomes the supply grill in this room. All of that air, instead of being returned to the system, means that your system is now down that much more in outside air. So you have to look at your outside air component of whatever the air source is for this space in order to ensure that you can function with that space properly. If you were doing this on one room or two rooms, and it's a fairly decent sized air handling system, then you could probably suffer through that. Maybe the building itself becomes slightly negative, and your air balance overall can overcome what that means, and the air handling system not even be adjusted. But I think it's important to evaluate what that really is going to mean in performance of the overall system performance. This is taking the HEPA unit and discharging it to the return, and this has obviously the ease of, or the ease of installation maybe gets to be a little bit easier, because you don't have to work around, well, do I remove a window, or is my window operable such that in the last example that I could exhaust outdoors. The consequence, though, is that in order to make this room slightly negative, which you would still want to do, is that this HEPA unit is actually discharging slightly more air than what the return grill air balance actually was originally intended for. So that means that in all likelihood, some adjoining rooms are going to have less need to return less return air. So those rooms would be slightly positive. Maybe that's okay, as long as they're not also housing suspected COVID patients, where then all of a sudden you're throwing off the balance of those rooms and creating unintended consequences of air challenges. Here, the approach is creating kind of a vestibule type portal in the hallway. And with that, this creates negative pressure of the space, and the air is then returned in the corridor. The air is then returned in the corridor because the return grill in the room is sealed off. And this is good and bad. Good in that it gets the noise of the machine out of the patient room itself. It does create some complications because you may do this without a door. You may do this with just a temporary visqueen barrier, and but it does create a complication just in that it limits your hallway a little bit, and then also it would in access for staff going in and out, they're having to constantly go through that space, and so hopefully that wouldn't slow them down in creating in the necessary care that they have to give. This configuration is where you actually just create a visqueen barrier around the bed itself, and the HEPA unit can be right there. The benefit is that you can create significantly higher air changes right at the bed itself. So in theory, it's creating a great amount of capture of contaminants at the patient. And then, but it does create also a barrier to care, if you will, because they have to continually go in and out of the visqueen area, and then also from a visual care standpoint, it does create a visual. Someone has to make sure they're gowned up before they go into that area, and so there's visual issues. Room recirculating units. I'm going to jump to the next slide real quick. So, just a reminder, what are room recirculating units, whether they're fan coil units or mini splits or package terminal units or even heat pumps. It's important to remember that those types of units where you're recirculating the air just in the space, they typically have less than 6 air changes. They have very minimal filtration. And so what would you do in a room like that with that type of equipment providing your conditioning? And what we might encourage you to consider is a configuration like this, so that room recirculating unit is only meeting the cooling air needs of the space, while this configuration ensures that the contaminants aren't also ultimately finding their way and building up within that room recirculation unit. If you can't do that, if that's not an easy option, then maybe something to consider as an alternate approach to dealing with is increasing the room exhaust, whether that's putting a temporary exhaust in, or it is increasing the bathroom exhaust as a means of accomplishing that. At the end of the day, we would say, whether that's a local or whether that's a system level exhaust approach, at the end of the day, what you'd really want to do is make sure that you consider sanitizing and then deep cleaning the recirculating room units coil and assembly after use, both between patients and then certainly after this event is over with. An alternate strategy, as we've seen and discussed within our group, based on a lot of different factors and the availability of equipment that you may have at hand, is some approach. This patient tent approach can be an arrangement that you could consider, and that has a HEPA fan filter assembly at the headboard. And then also even something as simple as, they make snorkel exhausts with HEPA for both soldering and specialized handwork of building things. And those may also be very handy ways to accomplish something and protect workers in the process. If you do commit a patient floor or a suite, we would certainly encourage and identify that you should have a vestibule that so that everything coming in and out of an area is controlled. And we had a conversation with some folks the other day who were involved with the Ebola, and they actually encourage that approach should really should be a one portal for inlet and one portal for exiting, and then because with that your approach to how you would deal with gowning, which is putting on your PPE, and your process for doffing, which is the matter of removing your equipment, especially in instances where folks you wouldn't want them intermixing if you could avoid it because of the potential for contaminant crossover. So we will likely update this slide and have folks consider that arrangement as a better practice mechanism. We've had a number of questions come up in regards to what happens if you're doing an operation for a COVID patient, and the approach that has most been discussed and recommended is the approach that that the CDC has always recommended for nearly 20 years in regards to dealing with tuberculosis patients, and that is you always want to have an operating room be positive pressure, and the reason for that is you need to maintain the operating room's cleanliness. Otherwise it's not serving its purpose. And while that's the case, in the instance where a TB patient or in this case a COVID patient were being cared for in an operating environment, then it needs to be considered, well, how would you protect that space? The CDC talks about you could have a negative pressure operating room, but really that's in academic medical centers, and very few other places have a actual space like that. And most everywhere else, what we would say is create a temporary vestibule, and that temporary vestibule has a HEPA unit that pulls air from both spaces, the operating room and the corridor. The operating room is positive, so that should be the case anyway. And the corridor and this temporary, assembly, whether it's visqueen or a pre-built, pre-manufactured box, the HEPA filter system pulls the air in and then discharges it into that corridor. But in doing so, you create the protective barrier for the operating room to be an operating room and positively pressurized as it's supposed to. We've also had conversations with folks who are turning their operating room into additional ICU bays, and the question would be why? Twofold. One is there's a lot of med gas, oxygen, electrical outlets, and there's also an anesthesia machine or anesthesia machines that you could reuse as ventilators in the process. If you were using an operating room, you would want to rebalance the air probably dialing the air changes down, just both from a noise standpoint and also for what the purpose is of the use of the space. Maybe also that affords you the ability to modify the outside air balance or use the air balance and then either exhaust that space directly or alternately HEPA filter and return that air, and even turn that air into establish that room to be negative pressure, remembering that it's no longer being used as an operating room, it's being used as something else. This has some, so here, what we've seen in the larger scale instances of converting space to all COVID patients has been that the return air is an air handler supplies air out to patient rooms. Instead of returning the air, what we actually do is put a temporary exhaust fan in and discharge all of the return air. So essentially your return air becomes an exhaust system. You block off that return connection to the air handler, and then the issue to address that you would need to address is how to make up all of the air that now is 100% outside air at an air handler. Typically an air handler is not sized to, from a cooling coil standpoint, to dehumidify and cool outdoor air condition air. And so you may need to put some supplemental cooling in preconditioning the outside air, either to a return air quality level or to or even a little bit further in order to use the cooling coil in the air handler only at the performance level that it was specified and designed and is performing at. One additional comment that we'd add is that you might consider or evaluate or even do lower the chilled water supply temperature to affect increased humidity capacity, dehumidification capacity in your air handlers if you're changing a number of air handlers and the like in order to address these surge conditions in multiple places throughout your hospital. Remember that VAV air systems vary the airflow. Well, if you're housing COVID patients in an area, what you would want to do is set them at a fixed air flow setting. So at the least, you would reset the minimum airflows to match the maximum airflows, or fix them at a specific air change rate number, air quantity, basing that on an air change goal. Remember that you're only going to get a certain amount out of a VAV box based on its specified capacity. So you don't say, well, I want 12 air changes in this room, but the box is only capable of 6 or 8 air changes ever. So, know what your equipment is, or check it if you can. It is important because fixed air changes ensure stable airflow and air balance conditions. It may result in increased cooling and reheat consumption. So, from an energy standpoint, that it isn't ideal, but this is a short-term necessity, and so we're all going to have to deal with that consequence. This is the CDC air change clearance rate. So if you have 4 air changes in a room, that means that 69 minutes after you've cleared a patient is when 99% of the potential airborne contaminants have been removed, the airborne contaminants that, you know, in a static condition. So we've talked about all of the activities that folks would do during addressing this within a healthcare environment itself, but there are also may become a time when you need to either by managing patients before they come into your door, or in managing patients in an alternate location because of either capacity issues or because of need in a maybe what is typically a more rural or remote site that needs to be addressed, or because of the scale of the issue that you're dealing with, and so addressing a capacity need beyond that. You know, so there's conversation around alternate care sites, as it's referred to. And the first question should always be, what's the clinical goal of an alternate care site? Is it for COVID suspected patients? Is it for non-COVID patients? And we'll talk about that in a moment. What acuity level is going to be needed in that space that we're considering? And then it's very important to remember, if you should ever diverge from true healthcare standards, that is being done by, you know, authorities that have responsibility and decision making around that. So that is your incident command system, however it is applied. We would definitely refer you to some ASHRAE resources that are posted that have some good information about that. So, you know, the most important thing in dealing with and planning for an alternate care site is staffing. You can talk all you want about space and supplies and all of the infrastructure needed, and those are very important things. But if you don't have skilled care providers, no space in the world is going to solve the problem that would exist. So it's very important to realize that staffing comes first. Really, at the end of the day, it does and will need to. Beyond that, yes, it becomes an issue to recognize, do you have all the supplies needed? The PPE, the beds, equipment, if that is part of it, and the necessary infrastructure. You know, sometimes it's important that the space is proximate to a hospital, and then sometimes it may not be specifically of the same importance. If you are working with any care site, access to toilets and hand washing is imperative. This is especially challenging in kind of large volume spaces, as we have heard and seen in some of the applications that have been put out there in the US. And I offer a little bedside toilet example just because that's not cool, but it would be necessary in some of those kinds of applications. I mentioned the ASHRAE resource. There's a CDC resource as well that's been posted just recently that we would definitely encourage you to look at when you have a chance. So what are those spaces? And I'm just getting close to wrapping up, so bear with me. One facility that we know built a tent, essentially like a tent setup outside their emergency department, and this would serve for screening of COVID positive and COVID suspected patients in different wings. and we all need to consider the weather factors. They built theirs on a wooden pedestal so that it was up in the air to avoid, for us, rain conditions being very possible. This location's in South Florida. The treatment bay, I think, is interesting to note. So they pump conditioned air into the space, and then you see the little port essentially on the side next to each treatment bay. And so the air is like a plug air flow that goes past the patient and then discharges out each one of those little ports. And then there's a little tiny electrical strip thing, to provide a little bit of electricity at each bay. This is at Vanderbilt Medical Center in Nashville. They converted part of their parking garage, and this is two-sided, so there's bays on one, not really bays, it's all just open, but they have the same setup on the other side of that wall, the temporary wall that they built. And in their case, they dropped a ceiling in so that the experience isn't so much less desirable, and also it manages kind of dust and so forth better than leaving the exposed concrete structure. But this is an open air. The garage is an open air garage. And this was a layout that we were working with some client to affect the same thing within their parking garage. This is the drive aisle. This is a handicap parking spot. But these are each patient bays essentially that they were laying out. And for them, they were going to install some sinks at each of the, at numerous columns. And this is the first floor of a parking garage. So the matter of how you do a sink at all, becomes a logistical issue. Most parking garages aren't equipped for plumbing. It just doesn't happen. Those conditions, those particular ones, were all managing COVID patients as they were incoming. So before they entered the emergency department, they were being triaged or pre-triaged even in a space outside of the emergency department. There's also the matter of decompressing your existing beds, meaning taking your post-acute care patients who are close to being discharged but aren't really 100% ready to be discharged safely. And so you move them perhaps into other spaces where they may need less equipment intensive needs, and then you can make those regular patient beds available to the more intensive needs that might be driven by your COVID patients, and move these patients to other spaces. So in this particular case, they repurposed an auditorium. You can see they covered the carpet floor for safe cleanup purposes. They just created some privacy with the screens, and you're off to the races. Everybody, obviously was carried in the news a lot, 250 bed facility at Jacob Javits Center in New York City. This is one of 4 250 beds that are being built at the Javits Center. Each of these, you can see the actual setup is reasonable sized, but it has really no equipment at all. And I don't even know, it really wasn't clear if it even had I guess it must have an electrical outlet, but that's about it. But the intent with this is the same thing as that auditorium space that was in the last slide. It's taking your post-acute care patients, getting them out of all of these New York City hospitals and into a space where they can be checked on and monitored, but they're less acute needs than the needs that are flowing into the hospital due to the COVID patient load. Some facilities have used, this is a manufacturer that creates Connex, the containers, and repurposes them as essentially ICU level bays, triage on one side and ICU on the other, and you know, that has great potential, but obviously there's a lead time, and most all the infrastructure is integral to the unit, so it's probably also not you know, the least expensive option, and depending upon what your need is and where it is, those are important things. Some last comments and thoughts, and then I'll open it up to questions. So from an infrastructure standpoint, I mentioned a little bit that your oxygen usage definitely gets higher due to the COVID patients all very frequently requiring respiratory care. And so it's really important you recognize what is your bulk oxygen capacity, making sure that your refill plan is in place. Also that all the ancillaries associated with oxygen usage, your biomedical resources from hoses to masks to nebulizers and all that stuff are in place. For the most severe patients, they've been needing ECMO, which extracorporeal membrane oxygen, I'm sure I'm mangling it, but it's a very specialized care, and so just know that may be out there. And then, you know, make sure you're, you know, just because we're heading toward that time of year where maybe your emergency generator system, whether it's hurricanes or not hurricanes, just make sure your emergency generator system and your fueling is good. There is a Kaiser document in regards to oxygen capacity as they've seen in their hospitals, and they've made that a resource. So if anyone wants to know more, I can share that. Finally, you know, code compliance we talked about, you know, but make sure that you've documented what you've done. Make sure you've developed an interim life safety plan if you've made changes that would affect that. And then, you know, have a disinfection plan for returning all of your systems back to the steady state of what it was before all this came about. One of the most recent notes that we'd seen information on, this is just within the last couple days, was reusing PPE gear by using autoclaves. And so you can look online for SaniPack for guidance about what that is. But this includes the gowns themselves, which can be a huge challenge presently. There's been a lot of talk about using ventilators for multiple patients at one time. And it's important that we make sure that folks are aware that, you know, this group of fairly you know, esteemed organizations have really come out against doing that because of the clinical complications associated with it, and you can read more about that specifically. If you must, you know, anesthesia machine we mentioned, and although it's not recommended by ASHRAE, if you must, because you only have one ventilator and you have the need and you have the expertise to do something other than that, there are resources. The New York Presbyterian created a highly technical document in how to do it, but yes, it requires respiratory care people who are truly skilled at what they're doing. We talked about protection and the fact that intubation is probably one of the highest instances of exposure by or for healthcare workers, and some folks have applied using this intubation guard. In order for the head placement, you may need a second healthcare worker in order to help the head placement for when the person is doing the intubation, just to note. There's some additional information. The Handbook of Care is a document that's been created in China based on things, and it has some helpful resources as well. And then some other resources you can take a look at your leisure. Just a note from a decontamination standpoint, and Larry talked about upper air UV, and there is a 405 nanometer UV that is safe for patient applications, and actually has a style that may be worthwhile. I think that's going to be more of a long-term application as opposed to an emergency application. From a decontamination standpoint, infection control folks have talked about hypochlorous acid, whereas vaporized hydrogen peroxide is something that really has very specific applications and really requires careful use because you have to seal the HVAC system in order to safely use it. Overall, we would certainly encourage that you look at the ASHRAE COVID page. In addition, the ASHRAE TC 9.6 has stuff that we 170 and the TC 9.6, which is our healthcare technical committee, have been generating information on a continual basis. And then the ASHRAE website has some great resources on the COVID stuff as well. And we'd certainly encourage you to look at that. So with that, I would say certainly if you have any questions.
Yes, Michael, we actually have a couple questions for you. So one of the questions that we have for you, it's a pretty long question. In an existing medical care facility where there is an asthma nebulizing unit, should this unit be isolated from the AI room? What are your recommendations for these two care rooms?
It's a nebulizing room, you said?
Yeah, asthma nebulizing units.
Oh, yeah.
Should this unit be isolated from the AI room? What are the recommendations for if these two care rooms may be in close proximity with regards to relative pressures, or should these two units be in different locations?
So I think it goes to, and I don't know the answer to this, and maybe they know the answer to this. So I'll gear the question, or I'll gear my response and leave it a little open-ended based on what they expect the use is. So in my mind, an asthma nebulizing area may be for patients who have asthma, severe asthma, and that can be very straining to begin with. We're going to assume that they are not COVID patients, and that room wouldn't be used for COVID patients. So if they were just severe asthma cases and they needed a space that they were being treated in, you would want to keep that space as far away as possible from COVID patients as possible, as you possibly could, and keep the space far away from. And ideally sealed away from COVID patients, because if a person with asthma or severe asthma were to come down with COVID, it very likely could be a life or death issue for them. In the instance where you're using that asthma nebulizing room for treatment of COVID patients, then you would want to treat it in the ways that we talked about in regards to treating it almost like creating an AII room out of that type of thing, because nebulizing is an airborne can be an airborne generating procedure, and so you would want to treat it as such.
Yep. Next question that we have for you. Can you share the link for sterilizing the N95 mask in the chat, or give us a quick summary on how to do it?
The N95 mask, I cannot speak to exactly how to do it. Unfortunately,
VJ can give some information on that. VJ, are you there?
Yeah, I'm here.
Okay, and can you give us some feedback on whether or not the N95 mask can be sterilized? I know we spoke about it last week.
I mean, from a purely the effectiveness of the mask point of view, you can sterilize it, but the bigger problem with an N95 is to be effective will most likely destroy the mask if you use UV or heat, or in some cases high doses of peroxide. But most important, by the time you're ready to or you sterilize it, the mask's effectiveness is already gone because it's a single-use mask. No amount of regeneration will restore its original efficiency.
That is the challenge. If you are a facility worker and they give you a N95 mask, you may be able to reuse it, but you need to have a care approach with how you're dealing with the mask. And that's unfortunately what we've heard as the worst case scenario, where these devices are becoming they don't have enough of them, is how they're applying reuse of them, and how they're hopefully safely doing that.
I mean, today I've got 12 calls about the same question, but 99% of the commercially available N95 masks use charged media. And when you use them, the charge goes away. So an N95 most likely ends up like an N10.
So one of the interesting things that I was reading about actually just today was a physician at University of Florida, Shands Medical Center, and they are repurposing the material that you put on, just to protect sterilized equipment, the halyard paper, I think is what they call it. And they're actually taking little cuts of the halyard paper, because that stuff actually is like 90, has like a 99% efficiency. Actually, you can breathe through it, and they are using that, cutting it up and using that as an alternate method for that. Now, I don't know that would be applicable as a, I don't know that anyone would say that is the same as an N95. No, it's not. But if you can use it to either as an alternate thing, so that your N95s are only used for the worst case conditions that your healthcare workers are experiencing, then maybe it allows you to lengthen the use of the supply that you have.
Okay. Next question for you, Michael, is in the opinion where HEPA filters is returned to the. Let me repeat. In the option where the HEPA is returned to the system, would you recommend a sealant void return or a ducting return to the air handler room?
Just repeat that last part.
Would you recommend a sealant void return or a duct return to the air handler room?
Well, if you have a ducted return, then certainly that's always going to be best, and we would always encourage a ducted return system in a true healthcare environment. If you don't have a ducted return, it's very hard to put a ducted return system in. Some outpatient environments just have a return air plenum system, and that it is what it is. So I think you'd have to just accept that fact, and in that case, maybe it would never be the best thing in the world to just discharge that right up into the ceiling plenum. I don't think that would be the best case scenario. I would really encourage avoiding that if you could.
Okay, cool. Next question. In temporary tents that are being used to handle COVID patients, we have to use standard split system units, which can't move air through HEPA. What about using Merv 14 or 15 filters instead of HEPA since they have a low velocity? What's your opinion on this?
I think the answer's got to be no. It's just not going to be the filtration level adequate for the capture, that is involved in what we're talking about here. And this goes back to Larry's slideshow, which talked about, we don't know what we don't know. And unfortunately, with that comes a level of maybe it's precaution today, but maybe it's the right thing. And with that comes, what happens if we didn't do the right thing? And HEPA filter is the application that we would typically always apply for something like this, because you're going to have a much higher rate of capture than any other Merv filter would do.
Okay. And the last question that we have for you, Michael, is in the parking garage or tents, are you adding UVC or HEPA units?
No, in the tent, because it's a once through air system, then no, we're not. In the open air garage, right now today, it's open air. That's the way that the owner has approached that. So in essence, you could say that they're actually not in the hospital for all intents and purposes. They are outside the hospital, just in the way that if you had, an airplane crash or something else, and they were being treated in a mass casualty configuration, you're doing what you can. That's kind of the mindset almost behind that. And the intent, at least, is with it being open air, there's a sea breeze, it's constant, then there's a heavy level of dilution occurring, and that is your protection mechanism, as well as obviously the placement is pretty far apart, and so the challenge becomes one on the staff, because people are having to walk a lot of steps in order to care for multiple people in and amongst that entire space.
Okay. If that's all the questions, because I haven't seen any other questions pop in. So if that's it, thank you, Michael, for taking your time to share all of this information and guidance with us. You can expect to get a copy of this presentation in your emails. And also, don't forget to register for the last part of this webinar series, where we'll have George Nicholson and Dr. Stephanie Taylor both giving their presentations next week. And we'll also have that'll be the last session. So I think if Michael, you'll be joining with us next week, Thursday, if you can. So if there's any other questions that anybody has missed out, Michael's email is at the bottom of the screen, and you will get an email with his contact information as well. So thanks everyone, and have a good night.
Thank you so much.
Take care.